Hello and welcome. Today we are looking at pediatric nursing concept and we are going to focus on GI anomalies. To be precise, esophageal atresias and trans-esophageal fistula. Well guys, esophageal atresia is a rare birth defect that normally affects the baby's esophagus. As we all know, the esophagus is the part that normally joins the tube leading to the stomach, right? Where food is temporarily stored. So the upper part of the esophagus, you find that in this case, it will not be able to connect with the lower part of the esophagus, all right? We have the upper part and now we have the lower part of the esophagus. Then they'll fail to unite, right? So it usually ends in a pouch, right? Which means that food can't reach the stomach. And if often or most of the time you find it is happening along with the trans-esophageal fistula. So they appear, the two conditions will appear in the same patient almost at the same time in most cases. Remember, that's where we have the esophagus and we can see its relationship with the trachea, okay, or the windpipe for that matter. So you find that this trans-esophageal fistula, it's now going to cause a connection between the lower part of the esophagus and the trachea. As a result of this abnormal communication between the esophagus and the windpipe, waste products in the esophagus are likely able to get into the windpipe, and this will result into choking, okay, and respiratory even depression, while also contacts of the respiratory system can enter into the esophagus, further causing GI disturbances. So, like for when the air they pass from the trachea to the esophagus, you find that the stomach acid will be able now to get also into the lungs. So the baby will not be able even to swallow safely, if at all, and it could result into developmental life-threatening disorders. So you can see on the proximal end the communication and also the distal end the communication. Of course, surgery is usually carried out within a few days of birth. Okay, we could do it immediately, or in some cases, which conditions we are going to specify, it could be delayed. On the developmental review, you find that esophageal atresia and trans-esophageal fistulas are both congenital anomalies, we have already said. So these organs involved here is the esophagus and the trachea, which normally grow together. But in the case of esophageal atresia and fistulas, they fail to separate. Okay, they fail to separate. If we try to review our embryology, you find that these parts they normally formed from the primitive foregut, and this is between the fourth to the sixth week. But you find that later in life they're normally divided by the transesophageal septum, which normally divides them into laryngotracheal tube, and which will be found anteriorly, all right, and now the esophagus, which will be found posteriorly. So in the due course of time, you find the laryngotracheal tube will normally form the larynx and the trachea, while the esophagus will try and elongate so that it can be able to connect to the stomach. But in the case of this disorder, this fails to happen. As a result, patient could present with coughing or choking during feeding. Postnatally, you could find they are now frothing, okay, or drooling from the mouth, because you find you have excess production or drooling in occur as a result of difficult swallowing and also pulling of saliva in the mouth. Others could present with vomiting, difficulty in breathing while feeding, blue tinted skin while feeding, and unusually rounded abdomen, even failure to gain weight for some of them. So, if you look at in terms of causes, you find that the cause is the exact mechanism triggering this esophageal atresia is totally unclear, okay? It's not fully understand as by now. But you find that both environmental and genetic factors normally play a role, right? So you find that now the esophagus during fetal growth will fail to elongate to get to the stomach. So this has been frequently associated with babies born with mothers who have excessive amniotic fluid, of course, that of over 2 liters, right? Or you find that babies with also abnormalities like the kidney, the heart, or the spine could also have a higher risk of having these disorders. Overall, you find that these conditions, the likelihood of having a child with this condition is very low, or the current statistics show that it could be 1 in 4,100 on 400 babies. In terms of risk factors, especially those who are related to mother, you find that there is positive correlation in the use of alcohol and smoking, mothers with uncontrolled diabetes mellitus, and exposure to antithyroid drugs like methimazole, right? And also increasing age. Those that are unrelated to the mother could include chromosomal abnormalities, especially the trisomy 13, 18, or 21, and also those with bacterial syndrome, like those who are presenting with spinal disorders, anal anomalies, heart problems, transesophageal fistula complications, kidney and limb are likely also to suffer from this condition. So this condition, esophageal atresia, has majorly 5 types. All right. The first one is the type 1, which is referred to as isolated esophageal atresia, right? Isolated esophageal atresia. So in this case, you find that the upper and lower segments of the esophagus will end in pouches. You can be able to see this one. This one is the superior, and this is the inferior part. Okay, all are ending in pouches. So that means we have now the middle esophagus missing. Okay, to be able to connect this. And if you look keenly, you'll find that there is no transesophageal fistula present. Okay, the esophagus and the trachea are not communicating at all. In terms of frequency, it normally appears like about 7%. Okay, 7%. And if we try to compare it with all the 4 subtypes, you find that it is the second most prevalent, right? Okay. The next one is type B, and in type B, you find that the lower segment ends in a blind pouch, which is here, this one, while the proximal esophagus is going to communicate with the trachea. You can be able to see it here. Okay, so in this case, you can imagine if there is food coming through the esophagus, it can easily get into the trachea, right, and the respiratory tract, and this is why we say there is increased risk of aspiration pneumonia, along with the other 3 C's of atresia, like coughing, choking, and cyanosis. In this case, it's also good to note the difference between type 1 and type 2. So in type B, no, not type 1, type 2, but type A and type B, so that in type B here you are seeing there is present of transesophageal fistula, okay, right here, okay, though this type is very rare for that case. The third type, which is type C, is where now the upper segment ends in a blind pouch. You can see the upper one is ending in a blind pouch, while the lower one is communicating with the trachea. Okay, it's also good to notice that we have the transesophageal fistula here. Okay, where the esophagus is communicating with the trachea in the lower segment. So as a result, you find that the patient could also present with the GI symptoms, okay, because of the gastric distension, where air gets into the GIT through this fistula, okay, so air coming in gets into the GIT to the dust. It's good to notice that this is the most common type of esophageal atresia at about 86%, right? 86%. in terms of prevalence. Okay. Next, we have type D, and type D, you find that trans-esophageal fistula will be present on both upper and lower segment. Okay, so we have the communication for the upper segment of the esophagus, and also communication with the trachea for the lower segment. Though you can be able to see that the middle part is missing, okay, it's missing. And if you look at in terms of statistics, this is the rarest form of esophageal atresia. All right. The last one is what we refer to as type E, or commonly referred to as the H type, of course. All right. In this case, we have no esophageal atresia, guys. Okay, you can see it is like H. So we have the esophagus, I have the trachea, and then there is the joining in between here. Okay, so in this case we have abnormal connection between the trachea and the esophagus, but the trachea and the esophagus are typically normally connected. So there's an abnormal communication between them. So usually they form this fistula, and it's often located in the region of the lower esophageal, lower cervix, or upper thoracic esophagus. So this anomaly can lead to issues like swallowing, respiratory problems, and recurrent infections for that. Okay, so this is the H type. Okay, all right, guys. In terms of diagnosing esophageal atresia, we could do a combination of prenatal suspicion and ultrasound findings, where in terms of prenatal suspicion, you could base on signs like polyhydramnios. And polyhydramnios, we've said, is where somebody is presenting with amniotic fluid excess of over 2 liters. Right, so this should raise the suspicion. In terms of ultrasound, we could find there is a purge sign and a distended fetal hypopharynx, okay, for that matter. So also following the birth, if a newborn displays signs like coughing, choking, and turning blue when feeding, you have to subject this child to confirmatory test to rule out esophageal atresia. So clinically, you could try by passing a thin feeding tube down the baby's throat, or it could be an nasogastric or orogastric. Gastric, and this, you find that in most cases it can't pass all the way. Okay, so you find that there is a blockage. Okay, additionally, you could do abdominal x-rays where you're going to observe the gastric bubbles, especially in type C, D, and E, except for A and B, because A and B we normally don't have communication with the stomach or the lower esophagus. Okay. However, we could do barium study, which is more definitive in confirming the diagnosis, where we do inject a small amount of water-soluble contrast material into the orogastric tube under fluoroscopic guidance, and we are able to see. You should also remember that we have to assess patients who are presenting with the Bacterial syndrome, because there is a likelihood that they could be also suffering from esophageal atresia. Well, surgery is the main treatment in this case. It could be immediate repair for healthy babies, where this procedure will be conducted in a neonatal intensive care unit under general anesthesia. So initially the baby can be provided with nutrition intravenously, and a suction tube may be used to remove this fluid from the esophageal pouch. Then the surgeon will make an incision on the right side of the chest between the ribs, just to access the affected area. The abnormal connection between the esophagus and the trachea will be closed off, and the upper and lower parts of the esophagus will be stitched together. We could also have delayed repair and staged repair in cases where the gap in the esophagus is substantial. You find the surgery may be postponed for a few months to allow the esophagus to grow, and this is especially in low or very low birth weight babies, moderate or severe pneumonia or babies with severe comorbidities or defects, right? So post-surgery, you could administer antibiotics just to prevent and treat any potential infection that may arise after surgery. The baby may also need a ventilator, okay, for mechanical ventilation initially just to assist in breathing until they are able to support on their own. We could also do a chest tube just inserted in the chest to drain any fluid or air that might accumulate in the chest cavity post-surgery. And also we could have supplemental oxygen may be provided just to support the respiratory function and ensure that there is adequate oxygenation. Lastly, pain medication can also be given to alleviate any discomfort associated with the surgery and aid in the recovery process. Okay guys, that marks the end of our video on esophageal atresia. You can go to the description section and practice the quizzes just to cement your knowledge and at least be familiarized with about this topic. Thank you.